which are the products which are distal to the block and which are the proximal. So the ones which are proximal will be accumulated while the ones on the distal will be deficient. So this was the one which we discussed last time in detail about how it looked like the overall pathway in that perspective. So we'll go one by one as to what defects will cause what manifestations, and then we'll go individually. So if you have a defect in DHC7, Smith-Lemli-Opitz syndrome, so essentially what you are saying that all three metabolites will be low. So you will typically present more with XY DSD and salt wasting. Now, of course, because there will be some other sources of cholesterol production, because you will get cholesterol from other sources as well. So it will not be absolute in that regards. Now, Dr. Manoj, if you have a LIPA problem, what will happen? So you will not be able to use that cholesterol. So first was no production of cholesterol. Now you're not able to use the cholesterol. This cholesterol is accumulating in the organs in which you got high cholesterol, like the adrenals, like the liver, the hepatosplenomegaly and other areas, and bone marrow as well. So this will present more like a Wolman syndrome in that perspective, and the manifestations are calcification and salt loss. Now, side chain cleavage and star, as we discussed, Naveen, last time, are quite similar. So you will have a milder disease, later disease. Maybe you may also have only isolated leukocorticoid deficiency like picture. If it's a very mild form, you can have that manifestation. But if you talk about the classical form, you will have DSD in. DSD and XY-DSD. So you will have XY-DSD, lipoid hyperplasia, along with salt loss in that regards. So now if you understand this, it becomes easy. So 17-hydroxylase deficiency, what effects will happen, Sayan, here?
17-hydroxylase female with hypertension.
Phenotypic female with hypertension. Because you have deficiency of the androgens and you have got excess of mineralocorticoid, which is coming, which is going to cause that. So 17-hydroxylase, we discussed hypertension and XY-DSD. So we'll be going into all this in detail, but this is more like a superficial overview in that perspective. 3-beta-HSD. So this is a very interesting phenomena, 3-beta-HSD, as you have said. You will, of course, have salt wasting, but because of peripheral conversion, you will not have absolute testosterone deficiency. It will cause DSD in both XX and XY in that scenario. Now, 21-hydroxylase, Dr. Manoj, I think that's very easy. So you will have hypotension, salt wasting crisis. Along with that, you will have XX DSD, and XY will present more like precocious puberty, peripheral precocious puberty. Now, if you go a step down, 11-hydroxylase, Dr. Naveen.
Sir, this was present with hypertension, hypotension, and XX.
So you've got increased level of both androgens as well as mineralocorticoid. So you'll have hypertension and XX DSD. So when you're classifying, you need to know what is happening to androgens, what is happening to mineralocorticoid, and then you will know which will be the manifestation. Remember, cortisol deficiency is nearly universal. When you say congenital adrenal hyperplasia, has to have a cortisol deficiency. What about 11-aldosterone synthase, Dr. Sayan?
Salt wasting.
So this will have isolated salt wasting. This is not really a congenital adrenal hyperplasia in the truest sense of the word, because there is no hyperplasia. So no accumulation of products will not happen. So you will have isolated salt wasting in that scenario. What about 17-beta-HSD, Dr. Vibha? Is it CH?
No, sir.
This is not CH because cortisol is normal. Then? So this will be complete sex reversal. So 17-beta-HSD, 5-alpha reductase, partial AIS, these three will present with XY-DSD, which will virilize in puberty, because you may have more production at that time. So it's XY-DSD. Now, what about aromatase, Dr. Manoj? So you have deficiency of estradiol and excess of testosterone. So both manifestations will happen. So you will have basically a XX DSD with maternal virilization, which is a major clue to diagnosis in that regards. What about the rarer form? What about the PAP-SS2 pathway, Dr. Naveen? Why?
Because there will be there is the DHEA except production, which is not converted to DHEAS.
So you will not be inactivating or storing DHEA. So your DHEAS will go up and you will have hyperandrogenism, a PCOS differential in that regards. What about hexose 6-phosphate pathway? What will happen there?
cortisol to cortisol conversion will not happen
Because why?
because the NADPH.
So they are the major source of NADPH, which is the electron donor. So you will not be able to produce cortisol. So what will happen?
In ACTH increase hyperandrogenism.
So predominantly hyperandrogenism. This is known as apparent cortisol synthase defect. So this will be the H6PCDH will have hyperandrogenism. So side chain cleavage star defect will cause salt wasting, and they will cause XYDSD and delayed puberty in girls. If you have a 3-beta HSD problem, you will have salt wasting and DSD in both groups of individuals. If you have 21-hydroxylase deficiency, salt wasting, XX-DSD, and boys will have precocious puberty. If you have 11 problem, you will have hypertension, DSD in females, precocious puberty in males. If you have aldosterone synthase problem, that is a simple salt wasting, no other manifestation. If you have 17-hydroxylase problem, you will have hypertension and XY-DSD. If you have beta HSD problem, you will have XY-DSD and delayed puberty in girls. If you have 11-beta HSD2 problem, you will have predominantly hypertension alone. Aromatase, you will have hyperandrogenism, which will happen. POR will have salt wasting and XX and XY-DSD. NADPH problem will have hyperandrogenism. And PAPS problem will also have hyperandrogenism. So if you remember the first slide and this slide, everything in between becomes easy to identify from that regards. Now, based upon what I've talked about, I've only focused on two things, mineralocorticoid and androgen levels. So based upon that, you can then classify clinically which form of CAH you are looking at. So if your mineralocorticoid is deficient and androgen is also deficient, what are you looking at, Naveen? So if you have androgen deficiency, it has very early star, side chain cleavage, 3-beta HSD, POR. Now, if your androgen levels are high, what are you looking at?
So then, and maybe in case we can have transit salt wasting.
And 3-beta POR will also come in there because they will have milder. So excess will also be 3-beta POR, but 21 will be the major thing. If it's normal, and so aldosterone synthase defect will be there. Now, mineralocorticoid is normal and androgen is deficient.
Then non-classical star.
No, I'm talking about more classical terms. So you have isolated androgen deficiency, 17-beta HSD. Androgens are excess. Everything is normal, androgen is excess. Yes, so it is very simple as that. Now, Vibha, excess mineralocorticoid and androgen deficiency. So mineralocorticoid deficiency, mineralocorticoid excess and androgen deficiency. So 17-hydroxylase. If you have mineralocorticoid excess, androgen excess, what is the opposite of 17? 11. If your androgen is normal, so isolated aldosterone excess, which one? No, which one? So you have features of mineralocorticoid excess, AME, apparent mineralocorticoid excess. So again, if you remember these 3 slides, you don't need to know anything else about CA. These 3 will give you the clue. Now let's go on to cases. Manoj, 3-month-old boy with micropenis and inguinal hernia was referred for surgical exploration. And then we saw the child. He had some facial features like upturned nares. What are you thinking about?
Sir, in 3-month-old child with the micropenis, with the palpable gonads, with these syndromic features, you have to look for the cholesterol.
And what else will you look for in the examination?
So there will be the microcapillary, upturned nares, and there will be the polydactyly.
Syndactyly, polysyndactyly will be there. So there was microcephaly, upturned nair was there. So you are thinking of a lipid problem or in the form of a Smith-Lemeli Oppett syndrome. Let's go into this algorithm. Now we look at mineralocorticoid. There was a mild hyponatremia and mild hyperkalemia, not very severe. So mineralocorticoid clearly is deficient here. Androgens are also deficient because there is micropenis, although there is no DSD. So this brings us to star, side chain cleavage, all those things. But as we discussed that seems to be a milder form, there is microcephaly. That's why we are thinking of Smith-Lemli-Opitz syndrome. Cortisol was on the lower side. You did a lipid profile which showed a low cholesterol. So this was Smith-Lemli-Opitz syndrome. So again, if you have androgen deficiency along with deficiency of mineralocorticoids, think of proximal defects starting from SLO. Now, Naveen, day 14 child with DSD, bilateral gonads are there. No uterus, 46X5. So this is XY DSD. And this looks like an androgen deficiency. Now, this child has hyponatremia and hyperkalemia. So what do you think?
Salt wasting with androgen deficiency.
So you have mineralocorticoid deficiency and androgen deficiency. So
the proximal defect.
yeah. So again, your testo is low. So you have to think of a proximal defect. And this turned out to be 17 OHP is high. Now, what are you thinking?
17 OHP, we decided we need to consider the 4 conditions. As such, 21 hydroxylase will not be there definitely. So we need to consider it as either 3 beta HSD, which is.
So mostly you will think of 3 beta because it's a male XY DSD. So that's why you have to think of 3 beta HSD as a predominant phenomena. So this is an individual who has got deficiency of both androgens as well as mineralocorticoid and a high 17 OHP. So it cannot be 21. It has to be 3 beta HSD defect in that scenario. Cyan, 3-week-old child with failure to thrive. There is, of course, atypical genitalia. The child's birth weight was 2,500. Only 100 grams were gained till now. There is severe hyponatremia and severe hyperkalemia. So what do you think here about androgen is high or low? And so what you are looking here is that mineralocorticoid deficiency is there and androgen is high. So what are you looking at?
21, 11.
So this is very, very classically 21. I would not think of 11 here because this severity of salt wasting will not happen because they will have DOC. So 11 will have mild salt wasting. They cannot have this frank salt wasting is impossible in that. So this is classically mineralocorticoid deficiency, androgen excess in a XX individual, 99% 21 hydroxylase deficiency. Mineralocorticoid deficiency, atypical genitalia in a XY individual, you have to think of 3 beta HSD as 90% of cases. So you need to also understand how common that scenario. So previous was quite typical of 3 beta HSD. This is quite typical of 21 hydroxylase deficiency. 17 OSP will be very high. So this is 21. We have a 1-year-old girl with atypical genitalia, Prader 3, no gonads, uterus is there. So this is a XX DSD. So there is a androgen excess. We know androgen is excess. Now the next step is potassium is 3.1. So mineralocorticoid is deficient. So you have now a scenario in which you have got high mineralocorticoid and you have got high androgen. So mineralocorticoid is high, yeah. So excess mineralocorticoid, excess androgen, only one diagnosis, 11 hydroxylase. So this is the classical case that I was talking about. Hypokalemia, XX-DSD, look for blood pressure. If it's high, it is mostly, this is the third scenario, 99% will be 11 hydroxylase. So if you just look at this algorithm, most cases you will get the diagnosis right. So this is 11 hydroxylase deficiency. Manoj, 8-year-old boy with early puberty. So we have a boy with early puberty. So which means androgen is excess. So we already have androgen excess. His bone age is 16. So often these people will have a fused epiphysis. That's why when we were discussing about some scenario of central precocious puberty where people were saying that this could be triggered central, this is not possible because by that time the bone age will be hugely advanced. So if your bone age is just close, it cannot be a long-standing CAH. Just as a side message here. So you have a child who is short, who has precocious puberty, fused epiphysis, pubic hair 4, but no gonads. What are you looking at?
It would be the XX.
So this is a XX-DSD and androgen excess. This is what you're looking at. What will you look at clinically? The next step?
clinical examination, there will be a hyperpigmentation or
Anything else you look at? Any boy with precocious puberty, look at blood pressure. So, of course, you will have hypokalemia, alkalosis was there was hypertension. So now you have mineralocorticoid is on the higher side and androgen is also on the higher side. So this is 11-hydroxylase. That was more of a milder form in terms of the genital phenotype. This is extreme form, complete reversal, the other way around. XX behaving like a female male in that regard. So this was again 11-hydroxylase deficiency. Now in 14-year-old girl with delayed puberty, height is 148, no pubic hair, no breast development. BP is high. So you have a hypertension along with you have got a female who is a development is there. What are you thinking about?
So in this case, first of all, I look at the height. Height is tall. So tall girl with delayed puberty with hypertension. So my diagnosis would be 17-hydroxylase or some beta SST. So since BP is very high, so 17-hydroxylase.
Okay. The next step is potassium is also on the lower side. So there is a hypertension. There is a mineralocorticoid excess that we know. There is inguinal gonad. So this is the twist in the story. You have got an inguinal gonad. So what do you think this is? Androgen levels are?
Androgen levels are low.
So you have excess mineralocorticoid with androgen deficiency. Your diagnosis is very simple, only one differential. That is, you're dealing with 17-hydroxylase deficiency. So this algorithm is very easily giving us where we are heading to. So this case classically is XYDSD with hypertension, 17-hydroxylase deficiency. If you did not have gonad, can it still be 17-hydroxylase deficiency?
Yes, sir.
Because females also, this is so sexual infantilism with hypertension. Think of 17-hydroxylase deficiency. Differentials are renal failure, of course. Of course, you will have other features. Then Turners can also have hypertension. But this is important from that regards. Cyan 4-year-old boy with recurrent stroke. Now, what we found out here is that this child had recurrent stroke and blood pressure was high. So that's why he was having a stroke, which is there. So mineralocorticoids are on the excess state. Then your potassium was 2.9, again showing the same thing. What will you look at now? Clinically, what will you look at?
The response to silent.
You will not look at whether he has precocious puberty or not.
Yes.
So first you will like to see what is happening to the androgen levels as well. So this child did not have any precocious puberty, normal genitalia were there. So this is no DSD, no precocious puberty. So now you have mineralocorticoid excess with normal androgen. So you're dealing with most likely 11-beta HSD defect. Aldo and PRA both are low. So this is what I was asking Dr. Vibha. What will you do in a normal looking male who has got low aldo PRA but mineralocorticoid is high? So differential, as you said, apparent mineralocorticoid excess versus you have got a EANC needle syndrome. So response to spironolactone will be looked at, and what we found here that there was a response, and this was 11-beta HSD, so AME. So again, if you have normal androgen and high aldosterone, think of a AME as a possibility. 6-month-old girl with failure to thrive, sodium is low, potassium is high, hyponatremia and hyperkalemia. So there is a mineralocorticoid deficiency. So now next step would be, this is a girl, you want to look at whether the androgens are high or not. So no pigmentation, genitalia is normal. So what are you looking at? Mineralocorticoid is low and androgen is normal. So this is the only differential will be aldosterone synthase or pseudo-hypoaldosteronism. We haven't talked about that because we don't know the aldo levels yet. So this is either in decreased production or action of aldosterone. So cortisol was normal, which means this is not a combined glucocorticoid defect. Then you look at the next step, aldosterone is low, which means it is an aldosterone synthase defect. So if you look at your scenario in which you have got a deficiency of mineralocorticoid with normal androgens, it is 11-hydroxylase. Next case, 3-year-old boy with failure to thrive. Pigmentation is there in the child. Brother died 2 years of age with similar illness, apparently also became pigmented at that point of time. Sodium is low, potassium is high. So what is happening to the aldosterone?
The aldosterone will be low.
Is low. So next step to look at.
So it will be both the androgen.
Okay. So now we know genitalia is normal. There is no excess or deficiency of that. So now what are you dealing with? You have got a isolated deficiency of aldosterone, which is what is looking like that. CYP11B2. What do you mean by that? CYP11B2? So 11 aldosterone synthase, is it likely or not? Like the one which we talked in the last case? Why is there a pigmentation there? So then isolated glucocorticoid deficiency. So you need to tell me which of these disorders can cause isolated glucocorticoid deficiency. So let's go further. So what we found here was that there was pigmentation. So that made a bit of a confusion. Now cortisol was found to be low. So you have this, typically you will say by the algorithm, this is 11 aldosterone synthase. But because of pigmentation, we were not accepting that as a possibility. So we did the cortisol level, which was low. So which of these defects is, it is an inherited form. Both brothers are affected, most likely autosomal recessive. There is pigmentation, there is normal genitalia.
But it's aldosterone, glucocorticoid resistance. It makes glucocorticoid synthase 11 beta HSP 1.
So when you say familial glucocorticoid, this is a differential of familial glucocorticoid deficiency, isn't it? ACTH resistance syndrome.
But the cortisol will be
ACTH resistance, cortisol will be high.
glucocorticoid resistance syndrome.
ACTH resistance.
Okay.
FGD, familial glucocorticoid deficiency. This is a classical presentation of FGD, familial glucocorticoid deficiency, in which you will have a later presentation with pigmentation, failure to thrive, hypoglycemia, some hyponatremia, hyperkalemia will not happen. So this is classical presentation of MC2 receptor defect. But can any of these enzyme defects cause the same scenario? So if you have a non-classical form of star defect, that's what I said. Non-classical star is a differential of FGD, in which you have some aldosterone which is being produced, while there's deficiencies predominantly at the level of that. So if you remember that child who came just to our on-site course, who presented with the same scenario, and when we got the genetics done, it turned out to be a star defect. So remember that although the classical teaching is that star will cause salt wasting, it will cause DSD and everything, if you have a milder defect, it may present like that in that scenario. So this is a classical picture of FGD versus maybe adrenoleukodystrophy also can present more with isolated glucocorticoid. That's why we got the genetic testing done and it was found to be star defect. No, star defect. This is Hamza. That case, it was star defect which was found. It can be. So, but DAX usually, isolated glucocorticoid deficiency again will be less likely. Because the adrenal, like that child was DAX, but he also had mineralocorticoid deficiency. The one you manage. Yes. So basically what we need to understand is that there are differentials of FGT. And if you read about that when we talk about adrenal, we'll talk about more. Isolated milder form of star also comes up there as one of the differentials. 16-year-old girl with primary amenorrhea. Height is 166. So a good tall girl. Then breast stage is B1, P1. There is inguinal gonad is present. Blood pressure is normal. What are you looking at? What about the androgen levels here? Low or high? What about mineralocorticoid? Normal. So you're talking about a scenario, and of course this is a XY DSD. There is gonad. So there is a XY individual who presents as a normal looking female. What you're looking here is that mineralocorticoid is normal and androgen levels are low. So this is 17 beta HSG. Just a mirror picture of 17 hydroxylase. There you will have hypertension. Here you will not have hypertension. So again, if you look at the algorithm, if you understand the physiology, it becomes very easy to identify this specific scenario. So this is 17 beta HSD defect. 3-month-old child with atypical genitalia sign, no palpable gonad, uterus 46x6. What do you think?
Salt wasting but present count.
So this is like androgen excess. Now your next question is salt wasting. No salt wasting.
So then maternal.
You will ask for maternal virilization. So again, here there is no pigmentation. Sodium potassium is normal. So this is androgen, mineralocorticoid level is normal and androgen levels are. So this is aromatase. 17 OHP is normal, maternal virilization, aromatase. And the clue which we got, I think you worked up this case, was that there was no increase in phallic size from birth till this point. So this is classically aromatase deficiency. So if you now look at this algorithm carefully, just have to answer 2 questions. Mineralocorticoid, low normal high, and androgens, low normal high. You will get these 8 different forms, and there you will be easily able to identify them.